Okay, good evening. Great service count. My name is Mike Fisher. I'm a nurse anesthetist. It's a certified registered nurse anesthetist, or CRNA, and I am trained in pain management. So in addition to my anesthesia responsibilities here at Summit Pacific for our GI Center, I see patients for pain-related issues, and that's what I would like to talk to you about today. Hey. There we go. So, just to go over and familiarize you to what we do with our pain service, talk about how the referrals work just briefly, and then describe what a normal visit is. I say normal because there's no such thing as a normal pain patient because everybody's got their own individual issues. But in general, we'll talk about what a visit looks like. So just a funny picture here. Remember, I'm not a doctor, I'm a nurse anesthetist, but when I talk to the patients, I'll say, how is your pain? What are you feeling today? And they say the normal amount. I say, well, the normal amount is 0. And then they look at me and we all get a chuckle because chronic pain is chronic. It's always there. Another neat photo that I found on the left side of your screen, chronic pain statistics worldwide. And it was really interesting for me. I had to look up and see what in the world is going on in Iceland. And the top 5 causes of people living with pain in Iceland are because of low back pain, major depressive disorders, neck pain, falls, and musculoskeletal issues. Well, that makes perfect sense. And since it's Iceland and it's cold and it's very similar to the environment we live in, it's cold, it's icy, it's wet, it's a little bit reflexive of what we're going through here. The countries that are the lowest percentage of chronic pain in descending order is Japan, number 5, Philippines at 4, Canada at 3, that surprised me, Belgium at 2, and Malaysia at 1. So I just thought that was pretty neat. Those are the countries with the least complaints of pain. Another neat demographic here, chronic pain, or low back pain, is the number 1 cause of disability, work-related disability in persons under 45 in the U.S. Looking over on the other side of the screen, it is the second most common reason reported for missing work, and it's the 5th most common reason for all healthcare visits. 80% of people in America are going to suffer some type of low back pain at some point in their lives. It's a $50 billion cost annually dealing just with chronic back pain. So what is the Summit Pacific Medical Center Pain Service? What do we do? In addition to interventional pain management, where I do nerve blocks with local anesthetics, some people will need what are called ablations, where we use radio frequency to disrupt the nerve messages going from your pain area up to your brain so you don't feel the pain. There are steroid injections. There are muscle injections for trigger points where you get those big nasty knots in your muscles. There's joint injections. So there's several different types of procedures that we do, and the visit will include a full evaluation, talk about your history, talk about what you're feeling with your pain. And it's very rare that pain patients have one complaint. Usually there's multiple things, because you didn't get here overnight into this chronic pain state. So we make a list, and sometimes we have to prioritize what's your number 1 pain complaint and go from there. After that is done, if you already have imaging, MRIs, X-rays, things like that, we can go over those together. Pull them up on the computer if they're available. We'll talk about what we see, talk about where your exam showed me your pain, talk about reports and different things in your record. If there's no imaging to review, well then at that point we may need to order some imaging, which may include MRIs or X-rays, things like that. With MRIs or certain imaging, we have to get pre-authorization from the insurance company. So there might be a lag getting your imaging ordered, but we try to do it as quickly as we can. And once your imaging is done, we bring you back for a follow-up visit to read the images and to confirm your exam. I like to see, okay, let's confirm your exam. This is where your pain complaints were. And then we look at the imaging together and we come up with a plan. The goals is we would like to confirm what your primary care provider referred you for, or what you've been experiencing, or find out what's causing that area of pain. And the idea is to complement the treatment plan that you've already come to with your primary care provider when possible. And if we need to add to or move things around, I do communicate with your primary care providers so that we can give you the best overall coverage to get you back to function where we want you to be, where you want to be. Again, normal. The treatment pathway that we try to use, and it's not a set in stone that we must do 1, 2, 3. It's not that, but the normal pathway is lifestyle modification. And that is very easy. It's simple, it's effective, but it's not always done. And that's because, well, you're in chronic pain. How easy is it to modify your lifestyle when you've got this chronic condition that's holding you back? So we talk about lifestyle modification, but a lot of patients will come in and they say, every time I come in, they say, lose 50 pounds, quit smoking, quit drinking. And that's the only fun thing that I can do because I'm always in pain. And we say, okay, we're not starting there. We're going to look at lifestyle modification. It's simple things. Maybe drink a little more water, not so much soda, just simple things, but we talk about it together during your pain interview. We talk about activity modification. And that would be, well, what can you do and what would you like to be able to do? And how can we get you there? I'm a big fan of yoga. I'm a big fan of physical therapy and just an active lifestyle. And today it is gorgeous outside, so I'm wondering if that's why our attendance in the office is a little lower than normal, because it's so pretty outside. So since it's sunny, it didn't hurt my feelings, but next time, let's just go. Anyway, the next thing will be therapies. I always get an eye roll there from the patients. I've already done physical therapy and it didn't work for me, or I don't need behavioral health because I'm not crazy. Okay, I got you. But the reason we try to get you into physical therapy and occupational therapy, those guys are pros at movement. Well, if movement is what is hurting you, who do we want to talk to? We want to talk to the movement people. So I always like to get their input. Which muscles, which bones, which areas, what things can we do to help these patients get to where you want to be? And then behavioral health. We don't say behavioral health because we think you're crazy. In my case, when I was in chronic pain, I wasn't crazy, but it hurt so bad I was not dealing with it effectively. And working with both physical therapy to give me tools on how to move my body, and behavioral health in how to manage my actions with the pain, you put those two pieces together with the pain provider, with the primary care, and other consults, surgeons, assistive devices, other things on this list, and you put them all together, and that's how we get a total package to get you feeling where you want to feel. Medical equipment would include braces, walkers, crutches, things like that. And then 5 and 6, that's my wheelhouse. That's where interventional pain comes in. I'll look at the medications you're on, look at different things that we could do. Can we adjust these medications? Can we switch this to this? And I have to work with your primary care provider because I don't want to change anything they've set you on. So that's where it comes into that communication pathway, and that's a big deal, or a big part of what we do here. Then we talk about the procedures, which I mentioned a little bit. I'll go into more depth in a little bit. After that, that's when I start thinking maybe we want to get a surgeon involved. And sometimes you'll go to a surgeon consult and they'll say, look, you don't need surgery, or you don't need surgery yet, or try to put off the surgery as long as possible. And they'll send you back to me in your primary care, and that's fine. We just want to make sure that everybody knows what's going on to get you the best care we can get. Then there's further diagnostic workups. What else can we do? What else do we need to look at? Any other tests? Any other imaging? And then consults and counseling. Whatever else we can do to help you. And that's a communication thing between your provider team and you as a patient. Who should consider pain management? Great question. I'm glad I asked it. I'm going to tell you the answer. So, anybody who's suffering chronic pain, but chronic pain is described as continuous or intermittent, on and off, pain that's lasted for more than 3 months. Now, if you sprain your ankle, yes, it probably hurts. But if it hurts for a week and a half, 2 weeks, it wouldn't be appropriate to come here because we're not sure what's going on. With chronic pain, you've had this issue for so long that there's a very specific pathway in your body. I think our laptop is doing something. There's pathways that are happening in your body that have developed that we want to address with the different techniques and procedures that we have. The next reason to think about chronic pain is when you cannot participate in the restorative therapies. So if you, now that doesn't mean you don't go, that means that you've tried the physical therapy and it was too difficult, and they said, look, we need to see you again when your pain is under a little bit better control. That makes perfect sense. But we need you to try it first because we want to know what you can do so that we know where to help you the best. But if you're having trouble doing any of these things, then it might be appropriate to come over and see pain management. The next reason is when you cannot tolerate opioid weaning, medication vacations, or any medication changes. If you just can't tolerate it, but the goal is to bring those medications down, that's a good time to come and talk to pain management because there might be something we can do to help you, or just look at your pain from a different perspective from what the other members of your healthcare team see. And then after you've done all of the combined therapy, that's the best time to come in because we've got all of these things, and really pain management is a lot of detective work, and we have to chip away at the mystery of what's causing your pain and how best to manage it. So once these therapies have been done, we see the full picture of what everybody thinks it is, and then we go from there, but it's always in communication with you and how we can best help you. These are some options that I think work, and then you get to make the choice and talk about that. I made this for the primary care providers. I forgot to take it out, but how do I prepare for my pain management visit? Well, get any images that were ordered. Have those done when you come in, if they're ordered. If they're not ordered, that's fine, because we're not sure what images we need to order. We'll come into pain management and then we'll order them. But if they're ordered, get them done first. If you're on your pain medications, take them as prescribed. We'll still talk about it during your exam, but I don't want you to come in in excruciating pain, so do what you need to do to manage as best you can. And then if you've got certain conditions, I would like it if you could have some type of a log or a diary of your pain, because that really helps. And in the cost consciousness of healthcare in America now, it helps us to tell the insurance companies, or just to have in the record, that this is a clear record of what the patient is experiencing based on this diary. And that just helps everybody. It helps us track your pain, diagnose what we think it is, and justify the expense. The other one that I neglected to put in here was complete the restorative therapies. If you were ordered to go to physical therapy, try to get that done. Try to participate as best you can so that I can read those notes and take them into account when we come up with your plan for pain management. Now, you've done your pain management referral, and we've talked about everything, and now I present this list of options that I think from a pain perspective may help you. And you say, Mike, no thanks. Well, okay, that's fine. I'm not here to force anything on you. These are options that you've got. But aside from interventions, if you're not interested in that way, what can I do? Physical therapy, but you can do it on your terms. I really like YouTube or just online resources. If you type in, for me, if I type in 50-year-old dad yoga, a guy like me doing great yoga that's good for me. So YouTube's very specific in what you look for. So look for some yoga, look for some stretching, look for back health, look for whatever, and just be very specific in what you're looking for online, and chances are you'll find it. There's occupational therapy. It's a little bit different from physical therapy. They help you function the best. And then some people do very well with chiropractic therapy. Some people don't. Everybody's a little bit different, so that is an option. Then there's topical compounds. You've probably seen baclofen or Voltaren in the pharmacy, in a cream that you can rub on your skin. Well, there's different things that we can come up with here that are not available over the counter. So we can come up with some different creams that may work for you. And then I mentioned yoga already as far as self-care. And then a lot of people have used CBD ointments, creams, oils, and some people are using marijuana because we're in Washington. There's different data that both support or don't really support that for pain management. But again, everybody's body's a little bit different, and I'm happy to talk to you about any of those things when you're here. These are just a few references. I've got some more pictures. Are we going to keep it on? Kind of breezed right through that. Okay, let's talk about demographics of pain. This is the nerdy number stuff, but I really like this part. So looking at the demographics for pain, the younger age seems to be more associated with increased pain after surgical procedures, while older age is more associated with degenerative pain. Pain in older individuals is a little bit harder to manage because pain in this group is often either unrecognized or mischaracterized due to it's underreported because they don't want painful procedures. They don't want their lifestyles limited. They don't want things taken away. And some people will tell me that they believe that pain is a process of aging and that that's just what they do is they have to hurt now. And there's different things that we as Americans have come to believe as far as pain. So age is a big one. With gender, women are more likely to seek treatment for pain than males are, but they're also more likely to experience a greater intensity of the pain and unpleasantness than male counterparts. Culturally, this one was kind of surprising to me, but culturally, after statistics are adjusted for income and adverse life events, the lines between pain in different cultures kind of blurs, but more a greater comparison would be the socioeconomic background of people. So socioeconomically challenged individuals are more likely to suffer from chronic pain issues. Skip a slide. Usually because of the job that they're doing. So when you've got office workers, they're going to have those types of pain complaints, but when you've got guys carrying logs and bags of cement, they're going to have a different type of pain. So based on the work that we do and the lifestyle that we live, that's going to be very predictive of the kind of pain that we report. Smokers reported higher levels of pain. Alcohol abuse is more common in persons with chronic pain, and there's evidence to support that alcohol dependence may be related to the same neurons and neurophysiology that creates conditions where chronic pain exists. So it's just an interesting finding. I thought that was kind of neat to put in there. Looking at the clinical factors, it seems kind of silly that the pain is a risk for developing chronic pain, but the most important clinical risk factor for the development of chronic pain is the presence of another site of acute or chronic pain within the body. So the best way to prevent chronic pain is by aggressively managing acute pain. 88% of people with chronic pain have additional chronic diagnoses, and those are associated with chronic pulmonary disease or cardiac disease or hormone disorders like diabetes or thyroid issues. Depression and anxiety and negative beliefs about pain are all related to developing chronic pain, but they're also related to having worse outcomes from chronic pain. So catastrophizing, 20 to 50% of chronic pain patients also have comorbid depression. Post-operatively, 80% of people report significant post-surgical pain, and it's kind of a duh. But in that group, 10% develop some type of chronic pain condition. So post-surgical chronic pain development is most often associated with surgeries with a high frequency of nerve damage, such as amputations, cardiac surgery, breast surgery. Or think about C-sections. There's nerves right along the sides of the belly, and sometimes they wind up with chronic pain issues, and sometimes they don't. It really depends on the surgical procedure. So there's different things that are going to put us at risk for chronic pain. Obesity is an independent risk factor for developing chronic pain, and it's usually associated with joint pains, muscle pains. So chronic pain reporting increases as the body mass index increases. And it seems like it's a vicious circle that the more this increases, the more this increases. But you'll see that on the next topic, which would be sleep hygiene. Poor sleep results in poor pain tolerance. So I'm in pain and I can't sleep. And since I can't sleep, I experience my pain in a worse way than I would. So again, this is adding on to this and adding on to this. So that's one of the things we talk about when you come for pain visits is, what's your sleep like? And that's why we ask. That's pretty much what I've got. If there were more folks here, I would ask for questions, but I see head nods, so I think we're all good. Are there any questions in the group here now? Well, so again, I am Michael Fisher. I'm a nurse anesthetist. I am certified in non-surgical pain management. I did a fellowship at Texas Christian University. I learned my anesthesia trade while I was in the Army, and that's how I got into pain management, because as a soldier, doing what soldiers do, I suffered a few injuries, and I had a nerve injury down my leg, and I thought my career was over. And I was not dealing with it well, but thanks to a very talented team of physical therapists, behavioral health specialists, and my primary care, I had an Army physician assistant that just really made it happen for me. And then I had my pain management team. Without that group of people, as well as my family and my friends that were rooting for me to do well, I don't know how I would be functioning now. But it worked so great that I said, maybe that's what I need to do. And I haven't looked back. It's been a lot of fun. And when we're doing pain management, I guess the takeaway here, and then I'll wrap it up, is with pain management, it's not just about reducing your pain. I'm also interested in increasing your function. So talking about my soldiers would come in and they'd say, hey doc, I'm a nurse anesthetist, but they call everybody doc. So, hey doc, it still hurts. Thanks for what you did, but I'm still in pain. And I say, okay, so pain has not changed. What about your physical activity? What'd you do in the gym? And they say, oh yeah, man, I did this and I hit my max. So these soldiers were experiencing higher functional return, but not as much pain relief. So then that helped direct the rest of their care. And then we were able to explain that to the soldier. Yeah, okay, maybe you were able to complete more repetitions in the gym because your pain was lower and you have a higher physical capacity. So those are things that we talk about when we come into pain. I'm excited to see you. We are working on using my chart to get you a pre-visit questionnaire to help fill out some of that stuff before you come in. And if you have questions, please let us know, and hope to see you soon. Thanks very much.
I do have one question.
Yes, ma'am.
If someone is on like an extended LNI claim, are they able to come see you while they are on LNI?
Longer answer, but the short answer is yes, they are. But if they're already on an agreement, I don't know that I can change anything.
Right.
And we can assess anyone, and then we can have new documentation submitted. That's fine. But again, if you're on a claim with an approved treatment plan, it's not as easy as saying that, hey, let's just add this. We may need additional approvals. So short answer is yes. The longer answer is there's some fine tuning we would have to do, but also yes.
All right, wonderful. How do you work with patients who come in and they're like, okay, I tried physical therapy once, and I came out hurting way worse. What would my next step be?
Okay, that's a great question, and I hear it quite often is patients will come in, they've done physical therapy, and it was so painful they couldn't complete it, or once they did complete it, they were just in agony the next day. That makes perfect sense. What I suggest to those folks is if you already have pain medications, obviously take it before you go. If we can get you in for the interventions that we discussed, then try to manage your pain and get you back into physical therapy afterwards. Everybody's a little bit different, but we do like to have a trial before we do the interventions, but if you tried it and you couldn't complete it, just like on the previous slide, we will see what we can do and then get you back into physical therapy. So there's several rules dictating how we do how we provide the procedures, but once we check the boxes and we do the best effort that we can, then we can say, okay, maybe we need to do this patient a little bit differently. So not everybody's going to fit into the same box. Does that answer your question?
Yeah.
Okay.
Yeah, absolutely. Absolutely. That's it.
Great. All right. Summit Interventional Pain Management. I'm Mike Fisher. Hope to see you sometime.